Does anyone have any questions for either myself or Jose? Could you go to the mic, please? Yes, sit there.
Okay, hello. My question is in regard to basically your last comment about basically the immediate impact of, let us say, Sutent showing up prior to surgery and perhaps extending some sense that there's benefit. Does that same early response, if it's shown in metastatic locations, does that also tell you an early response means a generally better outcome?
You know, I'm going to be honest and say we haven't looked at that, but I think that that is a very worthwhile study to do. I think that intuitively my answer would be yes, but I don't think anyone's done a formal study on that. But it's a very good question.
My question is, how should ablation and like the monitor of the small kidneys be modified if you have those multiple small, less than 3 centimeter, if you're like a tumor producer and you have multiple, I think you called them multifoci tumors or something?
Do you mean after or before the ablation?
Before.
If you're on active surveillance only?
Right, and you have multiple primary tumors that are less than 3 centimeters.
So this is more common in patients who have VHL typically, and or von Hippel-Lindau. It's a syndrome for patients have tendency to have more than one tumor in their kidneys, and the follow-up is still every 6 months or so. So we don't really want to image too often because of the radiation risks that are involved with doing too many CT scans. So we still do it every 6 months or so. Initially every 3 to 6 months, but then after the first year, probably move to every 6 months or 1 year. But also it depends if the patient is young and healthy. The question is, why would we want to observe? Now in VHL patients, that's done commonly because we wait for the tumors to become 3 centimeters before we intervene. So we don't want to do surgery when the tumor is still 1 or 2 centimeters in that particular patient population.
Okay.
Yeah, just to add to that, the 3 centimeters we're talking about comes from the NCI, where they have a huge experience in treatment of genetic kidney cancer, and they noted that those patients who had a tumor that was 3 centimeters or less never metastasized. So we use that 3 centimeter cutoff as sort of the trigger to tell us when we need to do surgery, and then usually in a patient who has multifocal disease, once it hits that 3 centimeter cutoff, we'll go in and debulk the tumor, or debulk the kidney, take all the tumors that we can take out, and then follow them over time. Question, ma'am?
Hello. I have a question on the ablation. Is that a option if you've metastasized to your lungs? Would they possibly use that on a tumor that's in your lungs?
You mean use it on the lung tumor itself, or on the tumor that's still in the kidney?
No, my tumor's gone from the kidney, but I've metastasized to the lung, and I've had CyberKnife. But is it an option to be used on the lung?
I think it is an option, but typically if it's doable by surgery, that's the preferred way to do it. Okay. The ablation for lesions outside of the kidney are mostly done for example, bone lesions where cryoablation or radiofrequency is done, because it's typically harder to remove a lesion from the bone compared to removing it from the lung, for example. But it's more commonly done for liver metastases, if anything.
Okay.
Yeah.
Thank you.
Yeah, it's more commonly used to treat symptomatic metastases, although there is some interesting research going on here at MD Anderson by one of our other colleagues, Serena Mateen, who's not with us today, where there may be some immunologic phenomenon associated with ablation, where patients we have some case studies that have been published where patients have undergone radiofrequency ablation, particularly radiofrequency ablation, not so much cryo, and had complete regression of their metastatic disease, almost like a vaccine kind of phenomenon. And actually, Serena is currently studying that both alone and in combination with some of the other immunologic agents that you'll hear about that Dr. McDermott will talk about, to see if that might be a viable treatment strategy in the future for patients with kidney cancer.
Yes, for Dr. Karam, after ablation, do you usually see necrosis in the body of the tumor? Can you see that during imaging?
You don't. You can see it afterwards. Typically, more common with cryoablation. You see necrosis, or what we call coagulative necrosis. It's basically like coagulating the tumor. That's typically seen on pathology if you end up removing that tumor surgically later on. So what we see usually is just absence of contrast enhancement. So the tumor initially, before the procedure, was lighting up when you give contrast. After the procedure, it stays dark. And that's our best indicator so far, in addition to biopsying, to make sure that the tumor is completely treated by frequency. So we don't see really necrosis on imaging as well as we do for larger tumors that Dr. Wood showed earlier in his talk.
Okay, during subsequent imaging, you might see necrosis.
You might, but typically what we look for is just absence of enhancement. So
Okay.
necrosis is not really something we reliably see or we depend on for follow-up.
And a question for Dr. Wood. Venous thrombosis, Dr. Wood, do you insert an IVC filter prior to surgery, after surgery, or do you consult cardiology to get that done, or is that helpful?
So it's definitely not helpful before surgery. In fact, it could be, you had a picture, right? Yeah. Well, we both have had patients where some guy, I'll be nice, some guy on the outside decided that it would be a good idea to put the filter in the vena cava just in case a piece of the tumor thrombus broke off, and made surgery extremely much more difficult. After the thrombus has been removed, in some patients we will leave a vena cava filter. A filter basically is like a screen that you put inside the vena cava so that if they have blood clots below that screen, the screen blocks them from going to the lungs because a large pulmonary embolus can be fatal. So in patients who do have evidence of clot down in their legs, we will put a filter in. But if they don't have any evidence of that, typically we don't.
Okay, thanks very much.
Mm-hmm.